In this section, we will discuss important anatomic features of the adductor canal and saphenous nerve block above the knee. As with any nerve block, a correct understanding of anatomy is the best way to achieve a safe and effective result. In these lectures, we will demonstrate some examples of how to perform these blocks. However, they are by no means the only techniques that may be used. In November of 2009, we published a brief review of the anatomy of the adductor canal. At that time, we also reported the first successful use of the adductor canal block as a motor-sparing alternative to more proximal blocks at the level of the inguinal ligament. Since this initial publication, there has been considerable interest in this technique as a means of providing motor-sparing analgesia after knee surgery. Prior to 2009, the adductor canal block was recognized as a method to produce proximal saphenous nerve block. In our 2009 report, we detailed a number of other nerves present in this compartment that explain why the sensory changes associated with this block are much more extensive than only the saphenous nerve. These include the medial femoral cutaneous nerve, articular branches of the obturator nerve, the medial retinacular nerve, as well as anterior and posterior branches of the femoral nerve. This slide shows an outline of the extensive sensory distributions on the medial and lateral aspects of the lower extremity that are affected by local anesthetic injection at the level of the adductor canal. Next, we will see a detailed anatomic dissection of the adductor canal. In this dissection of the medial aspect of the left thigh, the skin and subcutaneous tissue have been removed. In addition, the gracilis muscle has been detached proximally and reflected medially. Remaining are the sartorius, vastus medialis, adductor brevis, longus, and magnus, and the semimembranosus, semitendinosus muscles. In this image, the gracilis and sartorius have both been detached and reflected medially. With the sartorius reflected, the superficial surface of the adductor canal is visible. After incising the fascia between the vastus medialis and the adductor muscles, the femoral artery is visible within the adductor canal as well as the saphenous nerve. The saphenous nerve is the terminal branch of the femoral nerve. Note how the saphenous nerve leaves the adductor canal by passing superficial to the tendinous insertion of the adductor muscles. The tendinous insertion of the adductor muscles can be mistakenly identified as the saphenous nerve on ultrasound. After crossing this tendon, the saphenous nerve travels between the sartorius, which is reflected in this view, and the vastus medialis muscles before diving deep to the pes anserinus. The pes anserinus is a confluence of tendons from the gracilis, sartorius, and semitendinosus muscles that attach to the medial aspect of the proximal tibia. In this medial view of the left thigh, the adductor muscles are being retracted anteriorly to display the deep surface of the adductor muscles. The femoral artery can be seen passing through the adductor hiatus and into the popliteal space where it becomes the popliteal artery. This adductor hiatus, or opening in the adductor muscle, also marks the distal limit of the adductor canal. This dissection illustrates with suture ties the multiple nerves present in the adductor canal. These nerves include, but are not limited to, the medial femoral cutaneous nerve, the articular branches of the obturator nerve, medial retinacular nerve, and branches from the anterior and posterior divisions of the femoral nerve. Note the position of the saphenous nerve as it passes superficial to the adductor tendon. The blue arrow marks the point at which the saphenous nerve is no longer within the adductor canal. Thus, injections performed proximal to this point are anatomically within the adductor canal, while injections performed distal to this point are within the plane between the vastus medialis and the sartorius muscles. This diagram represents the tissue plane immediately distal to the adductor canal that is bordered by the sartorius and vastus medialis muscles. At this level, the saphenous nerve lies in a tissue plane between the sartorius and vastus medialis muscles, but the nerve itself is usually not visible with ultrasound. The adductor tendon is commonly seen in this space and is often mistaken for the saphenous nerve. These are simultaneously recorded videos of the ultrasound image and transducer position used to attain the image plane between the vastus medialis and the sartorius muscles. Starting at the superior pole of the patella over the vastus medialis muscle, the transducer is moved medial and posterior. The first tissue border encountered is the tissue plane between the vastus medialis and the sartorius muscles that contains the saphenous nerve. Blocking the saphenous nerve at this level is appealing since there are no major blood vessels in proximity to the nerve and the plane is relatively superficial and easily recognized. This is another example of a systematic way to identify the tissue plane between the vastus medialis and the sartorius muscles. Again, this plane is important because the saphenous nerve passes through this plane to the pes anserinus. Note that the transducer is initially placed over the vastus medialis near the superior pole of the patella. As the transducer is moved medial and posterior across the thigh, a prominent fascial plane will be visible. This plane marks the border between the vastus medialis and the sartorius muscle. In this particular example, the tendinous portion of the adductor muscles is visible and illustrated by the white arrow. As mentioned earlier, this hyperechoic structure is frequently mistaken for the saphenous nerve. Note that the saphenous nerve is not obvious in this image. This diagram illustrates a common challenge that can be present when performing saphenous nerve block in the plane between the vastus medialis and the sartorius muscle. The nerve is positioned in a discrete tissue plane between the vastus medialis and sartorius muscles. However, the saphenous nerve itself is rarely visible within this tissue plane. In addition, it may be difficult to distinguish whether injection is occurring within the investing fascia of the sartorius muscle or within the investing fascia of the vastus medialis muscle, or actually in the correct tissue plane between these two muscles as shown in the diagram. In this example, the injection is within the investing fascia of the sartorius muscle and will not result in an effective block of the saphenous nerve. One solution to this challenge is to use an in-plane approach with a needle that is pencil point and occluded at the tip. The needle has side fenestrations at 1 millimeter intervals on alternating sides of its distal 2 centimeters. In this way, there is successful distribution of local anesthetic to the saphenous nerve. The pencil point design also provides visual and tactile feedback as the needle is advanced across the fascial plane. In this example, the upper right panel shows the outflow pattern from a 20 gauge pencil point needle with fenestrations along the distal 2 centimeters. The ultrasound clip shows this needle being advanced in plane across the space between the vastus medialis and sartorius muscles. Note the distribution pattern that results from an injection of a 15 ml volume. This is another view of the left thigh showing the adductor canal with the sartorius and gracilis muscles detached proximally and reflected medially. The saphenous nerve is obvious in its dissection as it passes over the tendinous insertion of the adductor muscles. Less obvious, however, are a number of nerves that have exited the adductor canal and are visible in adjacent tissues. We have circled a number of these nerves. These nerves can also be visualized in the corresponding ultrasound view. An interesting observation regarding these findings is the distribution of sensory loss that results when a block is performed at this level using the fenestrated needle as displayed earlier. The resulting sensory changes after injection at the level of the superior pole of the patella are very similar to those observed after more proximal injection at the level of the adductor canal. Thus, the fenestrated needle provides extensive distribution of sensory loss without the need to inject at the level of the adductor canal. As an alternative to the adductor canal block, the fenestrated needle can be used to produce a block with similar sensory distribution that can be performed in a more superficial plane that is not in proximity to vessels. This slide shows a block performed using a fenestrated needle at the level of the superior pole of the patella. For this block, a 22 gauge fenestrated needle is used. Specifically, the needle has 8 side fenestrations at 1 millimeter intervals on alternating sides of the distal 2 centimeters of the needle, as seen in the upper right panel of this image. We see simultaneous video of the needle insertion, which is in plane at the lateral side of the transducer, as well as the ultrasound view. Note that the pencil point needle is used with an introducer. As the needle is advanced, there is tenting of the investing fascia of the leg, as well as the fascia separating the vastus medialis and the sartorius. After injection, there is extensive local anesthetic distribution within the fascial plane between the vastus medialis and sartorius, as well as within portions of the vastus medialis and sartorius muscles which border this space. Thus, there is reliable block of both the saphenous nerve and accompanying nerves from the adductor canal. This needle has recently been approved by the FDA for peripheral nerve block and is available by contacting www.imd-inc.com. Next, we will concentrate on the adductor canal. Thank you.